Oh, I want to ask you later how to get recordings to see one. My wife can't see this one tonight. Is there a way to see them later?
Yes.
Okay, tell me if you get around to it.
Well, I could do it right now while Rick's getting ready.
Okay.
So sometimes we send out that schedule for everybody.
Yeah.
On that schedule is the link to YouTube. So
Okay.
if you go into the PowerPoint, right? If you click on that thing, and then
Yeah.
you click the little wine glass at the bottom, that will activate the presentation,
Okay.
and then you can click on the links. You can click on the YouTube link, and then that takes you to where all the YouTube videos are.
Okay. Thank you.
All right, I'm ready to try it, and hopefully it will actually share the screen in a way that's meaningful. Wait a minute, let me make sure I've got the right thing here. Okay, so shall I go ahead, Bruce?
Yeah, well, I think I'd like Ed to just take a minute and introduce you, and get a nice formal introduction. Ed,
Okay.
And everybody else, please mute your computer, your Zoom videos, while we're listening to the presentation, unless you have a very important question to ask. Thank you, including me.
Well, I don't think Ed's introducing me. Is Ed even on?
I don't see Ed even in here, Bruce.
I don't either.
His
you
his
can't
camera's on.
Then you can't talk. There's no introduction. You can't talk.
Looks like
There are two Eds on, Edward Friedman and Edward Goldman.
I didn't see Ed Friedman. He's my brother.
Just below you on my screen.
no, but he's
Bruce, why don't you introduce him?
Well,
Can't
Bruce
hear
is-
you, Bruce.
Bruce.
You're
muted.
This is Rick Schuman. He spoke to us early in the pandemic about vaccines. It was one of the first meaningful discussions that we heard about vaccines that wasn't coming from a news source. And he actually works on vaccines. I believe he works on the materials that are used to make vaccines in some way. And that's about as much as I know about vaccines. And Rick, why don't you tell us a little more about yourself?
Okay, well, I have a small company called Antibody and Immunoassay Consultants. And as part of my work, I work with several companies that, it's actually part of the presentation, but we work on vaccine development for infectious diseases. And most of our work up until recently has been involved with bacterial diseases, with some work on flu. And so as part of that, of course, vaccine development in mammals is generally similar from antigen or from target to target, but the differences exist based on the specifics of a target. And so one of our biggest focuses happens to be on the adjuvants that are used to enhance the immune response. And with that, I think I should just go ahead and share the screen and we can move forward. So I'm going to hit the share screen button and hope that this works. And that's not getting me what I want. Here we go. Okay, and now let me do, this is a slideshow. Okay, now can everybody see this?
Do the up arrow.
Yeah, we see it fine.
Okay. Yes, this is my little reference to the anti-vax people. And I will let you all enjoy this for a second, but we're not going to stay on it for very long.
Hey, Rick, if you click on the wire glass at the bottom on next to the volume, you'll get get it into presentation mode.
Presentation mode, please.
Yeah.
I'm looking for presentation mode,
That was it.
and I don't see
So just go down there and hit that little hourglass right there.
that I'm on right now.
Go to your left.
It says slideshow when you hover over it. To the left.
The next thing to the left. Oh, next thing to the right.
That one.
There.
Got
Boom.
it.
Thank you.
Sorry about that. Okay, yeah, you can see it a lot better now, can't you? Yeah. Okay, so back to what I was saying. We develop, among other things, assays for measuring the immune response to vaccines, most of which, in fact, are viral and bacterial infectious diseases, and working with unique adjuvants. And I will give you a definition of adjuvants later, but the thing to take away in terms of what an adjuvant is it helps to enhance the immune response. Now, COVID-19, although I think everybody has an idea of what it is, just so that you know, the word COVID stands for coronavirus disease. And you'll almost always see the suffix 19 because it was first identified at the end of 2019, despite Rush Limbaugh telling us that there were 19 different versions because he doesn't know what he's talking about. It's related to some other coronaviruses, specifically SARS and MERS, which came about earlier. And at one point, SARS in particular looked like it was going to be quite a pandemic, and then it faded. And in the scientific literature, you can sometimes see COVID-19 referred to as SARS-2, which is a more official designation. Okay, so how does this spread? It's a respiratory virus, and respiratory viruses spread through the transmission of microdroplets. And I know you've heard that many, many times, and that's really how it works. This is very typical for all the respiratory viruses. And, it's the coughing and sneezing or talking, people expel the droplets. And one of the reasons that you always hear to stay out of crowded places is because people in indoor facilities where it's crowded, especially when there's other background noise, tend to speak louder. And the louder they speak, the more of these microparticles, these aerosols, get into the air. And what you want to avoid, of course, is for them not to enter your nose or your mouth. And usually 6 feet distance is far enough. But there are some studies that show even 6 feet isn't far enough to avoid transmission, especially in settings where there are a lot of microdroplets. The droplets can stay in the air sometimes for 3 hours, and of course that's all size dependent. The bigger the droplet, the more likely gravity is to pull it down. But you have to remember these things are so small that they can't even be seen, and so it takes a long time for gravity to pull them down sometimes, and they can hang in the air. And again, you don't want to be in a situation where you're breathing these suckers in. And as I was just referring to, the most dangerous places are indoor settings. And especially if you're in an indoor setting like a restaurant where people typically have to take off their masks. And that's why in a lot of indoor restaurants now, if there are any that are open, they have spaced the seating, so it's 6 or 8 or 10 feet apart. That's helpful. I'm not always certain that it works. And again, when you're in a restaurant, you have to take off your mask, and that's a problem. And there's other indoor settings too. And one of the issues, which we'll touch on briefly at the end, is that there's new variants, and some of these variants are more infectious, are able to infect more efficiently. And so maybe being exposed to the original virus and only getting a few viral particles isn't going to be as bad as with the new variants. It's too hard to tell now. It's too soon. And of course, one of the biggest and most troubling aspects of this disease is asymptomatic individuals can carry and transmit the disease. And so unlike with a lot of other illnesses where you feel sick and you have a good sense that you're really not healthy, with COVID-19, there are a lot of people who feel fine and they may be spreading the disease. If you get the flu, usually you don't feel 100%. You know there's something wrong. But with the COVID-19, especially for younger people, you just don't even know that you're sick. Okay. One of the things that has happened, though, you'll see in the world, is people are cleaning every surface all over the place. And so there's a lot of cleaning that goes on. This is not necessarily a bad thing, but there's a lot of over cleaning that goes on. There aren't any verified cases of individuals getting COVID-19 from surfaces. And this article that I quote here, or that I reference here, talks about it at length. And this was written by a group who are epidemiologists and building people. So they've had a lot of experience in this. And one of the guys is from Harvard, and it's a very interesting article. But let me just say here that because of the way I cut and pasted, not all of these are active links. And if you want to read this one in particular, you'd have to actually go to this. Well, this one you can click on, but there are some that you're going to have to cut and paste into your browser if you want to follow them. Okay, so your best protection. I know I'm reviewing things that you probably have heard before. Wear a mask and stay away from people who aren't wearing masks. There are physicians and epidemiologists now who will tell you to wear 2 masks. The masks, of course, they minimize the droplets that you breathe in from infected and from non-infected individual, and it reduces the droplets that you breathe out if you happen to be carrying the virus. And so it works in both ways. The mask will not eliminate all of the droplets that you breathe in, but they will reduce them significantly. And so it's important for you to wear them, and it's important for you to be around people who are wearing them. The combination can reduce the transmission to very, very low rates. And I think if everyone had been wearing a mask from last January or last March until now, our transmission rates would be much lower. The N95 mask is the best, and you can learn more about these. And I gave you a Newsweek article that talks about what you need to know. The KN95 masks, just so you know, are generally less expensive. These are made, I can't remember whether they're made in Korea or China. They don't quite meet the same standards as the N95 masks. And the usual other best protections. Avoid crowds, stay 6 feet or more away from others, wash your hands frequently, keep your hands away from your nose and your eyes, and get vaccinated. Of course, we'll come to that later. And one of the reasons that you're told to keep your hands away from your nose and your eyes is this. The virus needs to be associated with live cells before it can reproduce. Everything that you see when you look at a person in terms of skin, is all dead. So if the virus is sitting on your hands, your skin is protection for you as long as there's no cuts on your skin. And so the virus can sit on your hands for a long time and it'll just die eventually. And of course, if you wash your hands with soap and water, the virus will be gone. And the soap actually helps destroy the virus. So if the virus is on your hands and you touch your eyes or your nose, your eyes, the cells in the whites of your eyes are actually like mucous membranes, and they will allow the virus to come in and start reproducing. Same thing in your nose. You start to put your fingers in your nose, you're getting the virus into a spot where it can reproduce or be brought into your lungs or your air passages where it can reproduce. So that's why they are always telling you, wash your hands frequently. Okay. Now this is, okay. So COVID-19 is an mRNA virus. mRNA is the genetic material of the virus. Some viruses are DNA viruses. Now, all of us humans, we are DNA entities. And so our genome is in the DNA. And what happens is DNA gets translated into RNA in our system, and then the RNA is transcribed into proteins. And for the virus, it avoids the DNA portion of this, and it just has RNA, and it sends the RNA into your cells, and so it's translated into the proteins, and actually it becomes another virus. And it doesn't just produce one virus in the cell, it produces hundreds of thousands of viruses, which eventually kill the infected cells and pop out of the cells and go to other cells and continues that process. The initial studies that were done with this virus, which unfortunately had to be done on individuals at autopsy, found that the COVID-19 binds to a cellular receptor called the ACE2 receptor. And it's actually, the ACE2 receptor is actually an enzyme, angiotensin converting enzyme 2. It's involved in several, ACE2 is involved in several functions, including blood pressure regulation. But there's also an ACE1, which helps to modulate blood pressure also. So there's one that increases, one that decreases, and part of its function is to maintain homeostasis in terms of your blood pressure. In theory, if you blocked all the ACE2 receptors on cell surfaces, you would block COVID-19 entry into the cells. And in fact, in cell culture, you can show that that's true. But if you block all of the ACE2 binding sites, you'd upset the balance of the ACE1, ACE2, and it can be lethal. There are medications that that block ACE2 levels, ACE2 receptors at certain levels, and those have been used to control blood pressure, but they are not used to eliminate all binding of ACE2 or all the activity. Now, the other thing, when the ACE2 is inhibited, you also get other functions which include increased inflammation and cell death. And this is especially true in the lung cells. And those cells, the alveolar cells, are critical for getting oxygen into the body. So you can imagine, if you're just thinking about this, if you've got a virus that's binding to a receptor that lowers your blood oxygen level, I mean, this is one of the reasons that when the virus really gets raging, that people end up, that it becomes lethal, because you've got your loss of oxygen, and that's why people are put onto ventilators and people are put onto oxygen. So I have a little graphic of how this works. Oh, sorry. This was sent to me by a friend who's an MD, and basically it shows the virus attaching to the ACE2 receptor, and it brings its RNA into the cell, and then the cell has got an apparatus called the Golgi body, which then starts making thousands of virus copies. And it assembles them, and out comes the virus. But when it makes enough of the virus, it starts to kill the cells as the virus is leaving. I will say that this is not my writing, and so I apologize, but even on the internet, you can find misspellings. So, and one of the people who was one of the readers of this last night called me at 11 o'clock saying, "You've got to figure out a way to change this slide." And I said, I don't know if I can edit this, which I couldn't. So apologies for the misspelling. Now, this whole thing comes to work with your immune system. Your immune system, and we don't have to memorize this. We don't have to go over this in detail, but it's just gives you a sense of how the immune system works. And one of the keys is that there are cells called macrophages, and they're basically they're antigen presenting cells, and so they engulf the virus, and some of the viral proteins end up on the surface of the macrophages, and this starts to activate T cells, which help create B cells. The B cells are the antibody producing cells, or they turn into plasma cells, which produce antibodies. And they also help create cytotoxic T cells, which will kill infected cells. But what happens in raging infections where people die is that the T cells are starting to kill the host cells that are expressing the virus, but may not be ready to die themselves. And you can get what is called a cytokine storm. And that's the inflammatory process that makes you feel like when you've gotten injections before and you get inflammation at the site of injection, or you feel a little bit hot, or you're recovering and you have a temperature. That's cytokine storm. And a low-level cytokine storm is good. A high-level cytokine storm will put you into shock. So there's a balance that your immune system would like to establish. And if the virus is not controlled, then your immune system doesn't know any better, and you'll go into this cytokine storm. If you go onto the internet, you can get a million different websites that have pictures like this. And also there are YouTube videos on how your immune system works. And each one of them is slightly different. And some of them take 11 minutes, some of them take 4 minutes. And if you go to college to study the immune system, you'll be in for several semesters. So an 11-minute presentation is usually good enough to understand what's going on. It's not the same as studying this for years or for a year. Okay, so now the meat of this thing. Okay, we have to develop a vaccine. And COVID, they've identified 29 different proteins that the virus produces, which is not really that many. And they know that many of the proteins are involved in protecting the mRNA. They're polymerases, which allow the RNA to be transcribed, and some of them are structural proteins. But because they were already knew that binding to the ACE2 receptor was the key, they started looking at individual proteins, and with molecular biology techniques that didn't exist 30 years ago, they could produce all the individual. First of all, it's possible to have the entire genome of the virus, which is why when they express that genome, they know that there's 29 different proteins. And they could look at each protein and see which one was binding to the ACE2 receptor. And they found that the spike protein was the one that was binding to the ACE2 receptor. And what I don't what I haven't written out here is that on the spike protein, there's actually a smaller portion, which is called the receptor binding domain. And that's actually what binds to the ACE2. So further work, which is recent, has found that there's an enzyme called furin, which is found in most mammalian cells, and it cleaves the S protein into two subunits, an S1 and an S2. And the new studies have shown that the COVID proteins bind to both the ACE and this other receptor called NRP1. And I don't know whether it's S1 binding to one and S2 to the other. And I apologize for not knowing that. This was new to me 2 nights ago, so I haven't been able to find out the details yet. But binding to the NRP1 seems to facilitate the binding of the virus to the ACE2. And the other thing that they found is that since NRP is more abundant, and it's especially abundant in the nasal cavity, the belief right now is that binding to the NRP1 may be the reason why people lose their sense of taste or smell when they're infected with the virus. And so what they've also found in cell cultures, so this is outside of the body, and they've taken nasal cells that they can culture, and they have found that if they block binding to NRP1, that the virus is much less infective in those cells than if they allow binding to NRP1. And using genetic techniques, again, you can create cells that no longer have the NRP1 binding site. And it just gets reduction in the ACE2 binding, which means that it may be a second vaccine target. Okay. Let me just make sure. Okay. All right. So in terms of vaccines, I'll just do a little brief history here. And by the way, I'm sorry, I haven't checked the timing. Okay, I got to keep moving. So
your video didn't come through, by the way.
Not video.
I mean,
Presentation.
your presentation just disappeared.
It just disappeared?
Did it disappear on anybody else?
No.
Oh, it's
No,
still
I
good.
got it.
All right.
No,
I see the slide.
it's here.
Okay. Well, so I'm going to keep going because it looks like for most people it's there, and I apologize for those who can't see it. Yeah, Edward Jenner developed a smallpox vaccine. This was 1798. It was a long time ago. And he found that there were cattlemen who were exposed to cowpox and had very low rates of smallpox infections. And so he found that injecting small amounts of cowpox as a vaccine elicited an immune response that was protective against smallpox. In fact, there is some rumor, or there was a rumor in 1798, that he actually got this information from a milkmaid who also worked in his house. Maybe it was his girlfriend, I don't know. But what was important about this is that the cowpox and the smallpox are related viruses. And apparently the antibodies that were induced by the cowpox vaccine hit a spot on the smallpox virus that neutralized it. And so this was great. And other vaccines, now Pasteur used what they call attenuated cholera and attenuated anthrax. These are treated to be either non-infectious or have such reduced levels of infectivity that they are no longer lethal. And they induce protection, and he was able to induce protection against both these bacteria, which in the age of cholera especially was just a tremendously important move forward. Anthrax is still an issue, and the anthrax vaccines that are available are not great. And using attenuated bacteria is not usually used anymore. We'll go into that in a minute. But I'm not an expert on anthrax vaccines. I just know that there have been some problems with getting protection to anthrax. Jonas Salk, when he was trying to develop a vaccine against polio, fixed the polio virus using formalin, and that's a formaldehyde-like substance. And doing that, you kill the virus, of course. And the question then becomes, did you change the virus in a way that will now make the antibodies that you produce not relevant? And it turns out for polio, the formalin-fixed vaccine worked fine. And Salk was so confident that he vaccinated himself and his kids before this went into public use. And I'll get to one of the issues about that later in the next slide. Albert Sabin attenuated the polio virus, which was no longer pathogenic, but it still induced antibodies. And his vaccine, if I remember correctly, taking this, was an oral vaccine, whereas Salk, you had to take 3 injections. And I remember trying to run away from the doctor while my mother and sister held me down. I think I saw my sister get vaccinated first and she cried. She's probably on this call and can answer that later. But there's, of course, this is a brief history. If you want to look at a longer history, you can go to this site, and there are other sites that you can go to also. But okay, formalin-fixed vaccines don't always work. And one of the biggest cases on this was for something called respiratory syncytial virus. And RSV causes a lot of problems in premature infants. And so they've been looking for a vaccine for years. And they tried this formalin-fixed vaccine and gave them to, and they immunized premature infants. And it turned out that with the formalin-fixed vaccine, the infants got disease that had a much worse pathology than if they hadn't been vaccinated at all. Anti-vaxxers love this because they want to tell you that vaccines are not safe. And in this case, they didn't do the proper preclinical testing and to find out. And if you put this same vaccine, the formalin-fixed RSV, into an adult, you don't get any problems, because most adults, well, every adult who's listening to this has had RSV probably 100 times in their life, and they just think it's a cold. It's not particularly pathogenic, but when you're a newborn, it can cause lung consolidation, which will give you lung problems for the rest of your life. And so they've been looking for this. And with the polio vaccine, using the formalin-fixed vaccine, there were cases where the formalin fixation was not complete, and they injected the vaccine into people, and some people ended up getting polio from the vaccine. Anti-vaxxers love that also. What they have found with RSV, and which I'll mention again at the end, with RSV, one of the companies I work with now is owned by a man who is a co-patent holder on a drug called Synagis and another drug called Respigam. And these are anti-RSV drugs. And what they found is that in newborns who are born in the RSV season, which is winter, if they are premature infants and they are given Synagis, which is a monoclonal antibody against the fusion protein of RSV, it reduces the number of cases dramatically to almost to nothing in any hospital setting. And because almost everybody is a carrier of RSV, is very important in newborns, especially premature infants are considered immunosuppressed because they don't have full functioning immune response. when they're preemies, especially very low birth weight infants. A full-term infant who is born after 9 months of gestation, the last week or two of its life, their maternal antibodies cross the placental barrier, and so they are born with anti-RSV antibodies already on board. I digress. There have been many tries to make vaccines against a number of respiratory viruses, and most have met with very little success. And when I talk about respiratory viruses, I'm talking about what's called rhinovirus, which causes colds, adenovirus, which causes colds and can cause conjunctivitis, and respiratory syncytial virus, and there are some coronaviruses that cause colds. And because catching a cold as an adult isn't that big of a deal, the work on this has never been the highest priority. But now, instead of using things like formalin-fixed viruses, we can now look at specific targets. And this is the case, as we referred to, for COVID-19. And since the viral genome has been sequenced, it's possible to now say, okay, we only want to produce, we're going to use DNA that produces only the desired proteins, and these are called recombinant proteins. And this is done by creating DNA or RNA that codes for those proteins. You insert the genetic material into a bacteria or mammalian cells, which then produce the proteins for use in subunit vaccines. And alternatively, which is now what's happening with COVID-19, you can directly inject the DNA or the RNA, and they're used as genetic vaccines. And I made a genetic vaccine with a coworker in 1990. And it was such a crude response, and it was a very low level. And the colleague who was working with me, and he was the brains behind this, didn't really know at that point all that we needed to know in order to get the DNA and RNA successfully into the cells. And so I think in the next couple of slides, we're going to talk about that. Okay. As I've been talking about, we're using mRNA or DNA for the vaccine target, that codes for the vaccine targets. By the way, mRNA stands for, the M stands for messenger RNA. And this is the longest RNA that's in your system. And this is the RNA that codes for the proteins. Anyway, so what we're looking for is the vaccine target, which is a molecule that allows the virus to enter the cells, in this case, because we're talking about virus. A vaccine that binds to the target or inhibits or prevents the virus from binding to the cells and thereby renders it harmless. The vaccine, I left something out. The vaccine produces an antibody that binds to the target and inhibits it or prevents it from binding to the cells, and that renders it harmless. The theory that injecting the genetic material in the patient will induce their cells to produce the foreign protein activates the immune system, produces the protective antibodies. Now, you all, I'm sure, have heard of the Pfizer and Moderna vaccines, and in fact, many of you have probably already had them. These are the first mRNA vaccines that have ever been approved for human use, and they've received emergency use authorization. People have been working, Moderna has been in existence for at least a decade, probably longer, looking at how can they use mRNA vaccines to prevent diseases. And they've shown that the mRNA vaccines will work in laboratory animals, but hadn't had any success yet with humans. And part of the slowness of that process has been that the FDA has been making them take very small steps at a time before they could come up with a human, with a vaccine to use in humans. Under the current conditions, they wanted to move fast, and the FDA was much more willing to say, okay, we're going to give you emergency use authorization when you show us your data. There's a big advantage to this. When the virus changes, it's relatively easy for the genetic experts to say, okay, we're going to take another look at the new protein sequences by looking at the DNA sequences, and we can make a new mRNA vaccine in a month or 2 months. And so we're expecting the virus to change because they're a microbe and they're under pressure to change. And so this technology has that advantage. And so I'll discuss that a little bit later, but that's something to keep in mind. Vaccines. Okay, did I go past this? Yes, I just want to make sure. Good. I'm sorry, my mouse is that I'm moving the slides with is a little too sensitive. Okay, the current vaccines, Moderna's is an mRNA vaccine. It requires 2 injections, storage at -20 degrees. The clinical trials were tremendously effective. They said they had over 95% efficacy. Now, the way they did this is they compared 2 populations, one who got the vaccine and one who didn't. And they said, okay, well, the population that got the vaccines, only 1 person out of 100 got the virus, and the population that didn't, 5 people out of 100 got it, or some sort of statistical comparison that way. But it has seemed to be holding true as they do more and more follow-up on the clinical trials, and they're continuing their clinical trials. It seems like the efficacy is extremely high. For something like the flu vaccine, when they pick the right vaccine each year, if they get 70% efficacy, that's a real positive. So getting 90 or 95% efficacy is just amazing. Now, they've reported that so far, when they've tested the vaccine against the new viral strains from Britain and South Africa, that their vaccine seems to have efficacy against those strains. And they measure this by taking the antibodies from people who have been vaccinated and doing what's called a neutralization test. And if we have time, you can ask questions about neutralization test again. I pointed that out in the last presentation. The Pfizer vaccine is very similar to the Moderna vaccine, also requires 2 injections, also has a tremendously high efficacy rate, but it requires storage at -80 degrees Celsius. Now, most hospitals, most laboratories, most pharmacies have -20 freezers. A lot of hospitals and a lot of labs have -80 degrees freezers, but they don't have giant capacity 80-degree freezers. And so the storage at -80 is an issue in some areas. And just if you're CVS and you're giving out the vaccine, you probably don't have a -80 freezer, or you had to buy one so that you can handle the Pfizer vaccine. Now, and again, when the mRNA starts producing the S protein is translated, the mRNA is translated into S protein. The S protein leaves the cells. The antigen presenting cells, remember back at the beginning, those macrophages, they see this S protein and they recognize it as non-self, and it starts the whole immune process. Okay. All mRNA vaccines require a carrier, a lipid-based molecule. And as I referred to in the 1990s, when we were doing, it was a DNA vaccine with a colleague, we actually used a carrier that had never been used in animals before because it was the only carrier we could get. And it wasn't very efficient, and it was somewhat toxic. So for human use, they have to have a lipid carrier that is not toxic and is very efficient, which both companies have designed. They won't tell you the details of these lipid-based molecules. But they protect the mRNA when it's exposed before it gets into cells from being hydrolyzed by enzymes in the circulation. And those enzymes exist. And it allows it to move through the cell membrane, which is a lipid bilayer. It helps open that membrane up when it hits the ACE2 receptor. And then it enters the cells, and bingo, you've got this mRNA, excuse me, I shouldn't have said the ACE2 receptors. It just allows the mRNA vaccine to enter the cells. And then it uses the cell's genetic material, which is an RNA polymerase, to start producing the protein. The carriers are different. I know that this is inside information, but it probably explains why they need different storage temperatures. So let's go here. Okay, the other vaccines. AstraZeneca and Johnson & Johnson are using vaccines that use double-stranded DNA. This construct is much more rugged than an mRNA vaccine, and they're stable for a lot longer periods of time, and they're also stable at 4 to 6 degrees, which is refrigeration temperature. And almost any place that would be giving you a vaccine has got refrigeration capacity. Now, they both use an adenovirus delivery system. And the AstraZeneca adenovirus is a chimpanzee adenovirus that does not infect humans. And they deliver, and it doesn't replicate. So it doesn't replicate when it gets into the cell. And the J&J adenovirus also doesn't replicate when it gets into the cell. I don't know whether it's a chimpanzee or it's an attenuated virus. But it does contain the DNA coding for the S protein, which is active. And when the DNA polymerase sees it, it's able to translate that into mRNA, but it won't translate the adenovirus material. And so the AstraZeneca vaccine is actually the result of, they were working on a different vaccine using this virus, this chimpanzee virus, as their delivery method. And when the COVID virus hit, they transferred to this. And I believe they're doing this in conjunction with Oxford University. These are on board. The AstraZeneca requires 2 doses. J&J says they only require 1. I think the next slide is going to tell us something about J&J. Yeah, they announced on the 26th, which was recently, that they're going to report their phase 3 results next week. They had 45,000 people in 8 countries and 3 continents. They included South Africa. So they think that their results captured some responses to the one or both of the known COVID-19 variants. I would guess that unless there's some real big problem with this, that the J&J vaccine is going to start to be available sometime in late February or early March. Of course, they have to go through the same process that Pfizer and Moderna went through, which means reporting this to the FDA, getting emergency use authorization, and then the CDC putting their stamp on it that says, okay, you can give this vaccine to these kind of people. And they may have limits on age, they may not. And I will say, which I didn't include in this presentation, there are some vaccine makers who are looking at pediatrics. I don't know whether J&J did that or whether AstraZeneca did that. So, and pediatrics is important because we know that young people carry this virus and, again, are likely to be asymptomatic but can spread it. There are some other vaccines. And the other vaccine, which is my favorite, is the Novavax vaccine. It's called a subunit vaccine. The S protein is produced, they transfect or they insert DNA for the S protein into moth cells. Yes, they use moth cells, which grow great in culture. And the cells produce the S protein, which they have to then isolate and purify, which, as it turns out, the techniques for doing that are pretty sophisticated. And one of the things they have to be sure of is when they do this purification, they are not also co-purifying proteins from the moth cells, because that will cause antibodies to the moth cells, which could confuse everything and could be very toxic. But when they isolate the purified S protein, they attach them to nanoparticles. And since you're all physicists, I'm not going to explain what nanoparticles are, except to say that these are, for Novavax, I believe that they are using a lipid nanoparticle. And if you can imagine this lipid nanoparticle with S protein on its surface, if you remember the pictures that you've probably seen in the COVID virus, it's like this little circular thing with a bunch of S proteins on the surface. And so it looks very much like the actual virus. There's some advantages to this technique. The vaccine is stable at 4 degrees, just like the other ones, but it's probably stable for years. It's because it is produced sterilely, and it's very stable. It doesn't need to enter the cells. This, to me, is an important function because immediately your immune system sees these nanoparticles floating around, and it says, "Ha, here is something that's non-self." So from the time it's injected until the time the immune system sees it, it doesn't have to wait for the production for the mRNA to produce the proteins to get out of the cells, and it's not subject to the fact that, something I didn't mention, when the RNA polymerase changes it into proteins, sometimes there's reading errors and you don't get the protein exactly the way you want it. In this case, you don't have that problem. The other thing that I like about this is that the vaccine is combined with an adjuvant, and the adjuvant is a Quil A adjuvant, which is a saponin, and it's really enhances immunity. And I'm going to talk about what an adjuvant does in the next slide. Yeah. Okay. This compound, an adjuvant, is a compound that enhances the immune response by activating the T cells. And if you look back at that slide that I showed you, you can see where the T cells fit into this whole immune response. But it's like it supercharged them and they are super ready to go. The adjuvants themselves are not immunogenic. In animals, for years, we've used an adjuvant that is immunogenic itself, and differentiating the response becomes a little bit of a problem. We no longer use those adjuvants, but adjuvants have been used in human vaccines for a long time, especially the older ones are aluminum hydroxide and other aluminum salts. And if you've gotten a flu vaccine, some flu vaccines have adjuvants, some don't. When you're over 65, they recommend either the high dose flu vaccine, which doesn't have an adjuvant, or the adjuvanted flu vaccine, which is the one I prefer. I love adjuvants. Now, saponin, it's extracted from the Chilean soapbox trees. I have no idea what that is. And squalene are used in several vaccines. I use both of them in my work in mice, and they both work great. There's a general review of vaccines at this link here. It's not written in a very technical sense, so it's very easy to follow and very easy to understand. In any case, the reason I'm talking about the adjuvants is the Novavax vaccine, which I would guess will be available sometime in April. I think they will be reporting their their data to the FDA probably sometime in late February. I'm hoping it's earlier than that because I think this is the vaccine that I would hope that would be available for me when it's time for me to take the vaccine. So we will see if that actually happens. Okay, there's still companies working on COVID-19 vaccines. This is a resource that I gave you last time. It's in the New York Times, and it's kept up to date very well, and it's great. So if you want to take a look, and it lists what vaccines are in phase 1, phase 2, and phase 3 of clinical trials. It gives you some information on the clinical trials. When you click on the links that say, hey, give us more information for this specific one, they're going to make you sign up to subscribe to the New York Times. You don't have to pay, but you have to be listed in their list so that you're going to end up getting emails from the New York Times until you go crazy, which is not what vaccines are not supposed to make you go crazy. Okay, there was, in my last talk, I referenced that there seemed to be some association with MMR vaccines and reduced COVID pathogenicity. So here we got an article, and this was from a press release from the American Society for Microbiology. And I'm only quoting from this article from this press release, but it gives you really what you need to know. And that is, now, I don't know the units on the antibody levels, and I apologize for that. I suspect they're arbitrary units based on the standard controls that they use within these tests. And what they found was that it was the anti-mumps antibody levels that were correlated with, or inverse correlated to the COVID pathogenicity. And so when the antibody levels were above 134, all the patients who had COVID were asymptomatic. When the antibody levels were between 75 and 133, mild symptoms, between 33 and 74, moderate symptoms, and below 32, these are the patients who ended up hospitalized. And subjects who had not received the MMR vaccine in the same study, even if they had previous mumps infections, there was no correlation between their anti-mumps levels and COVID-19 disease. The anti-measles titers of the MMR vaccine and the anti-rubella titers were no way predictive. And so, yes, I've had 2 MMR vaccines in the past 4 months, but I did consult with my physician first. And anybody who wants to get an MMR vaccine, I'm not an MD, and you should definitely talk to your physician first. I will say that the side effects and the severe side effects with MMR vaccines are very, very low. But it does appear that natural infection is not the same as getting the vaccine. And one of the reasons that they started looking at this, at MMR vaccines, was because young people don't seem to get the disease as significantly as older people. And as it turns out, one of the theories is because all these young people have had several different kinds of vaccines growing up, whereas people of my age, and I'm 71, I didn't get an MMR vaccine when I was growing up because it didn't exist. Instead, I got mumps and measles and chickenpox, all those things. So it may be something that tells your immune system that it's turned on the immune system in some way, or it may be that there are common epitopes between the mumps virus and the COVID virus. I don't know. And again, the protection mechanism isn't known yet. The other big one is vitamin D. Now, from the Mayo Clinic, this guy, William Marshall, who's an MD, and there's a link below, he talks about this 489 patient study that was done. And they found that people with vitamin D deficiencies had higher rates of acute respiratory failure and mortality. And in a small clinical study with 50 patients, high doses of this vitamin D, of those 50s, only one had to go into intensive care. 26 patients who were not given the vitamin D, and 13 were placed in intensive care. These are not, the small clinical study was not retrospective, but it's small. And so while it seems to suggest that vitamin D is helpful, it's not 100% certain. So and I wasn't able to get the dose level on the small clinical trial because while it was referenced in his article, I didn't get the actual reference yet. So I only got that 2 days ago, and I apologize for not having that reference. But if you want to take high doses of vitamin C beyond what you get when you take Centrum Silver, check with your doctor first. Taking large doses of any drug without checking with your doctor could be a problem. And I don't want anybody doing this saying, well, Rick said I could take high doses of vitamin C. I'm not saying that. I'm saying check with your physician and see what your physician says. Okay, so this is from the CDC, and this is through the 24th. And it looked like the COVID cases were trending down. And if you look, however, at the number of deaths, also through the 24th, the COVID cases look like maybe they're going down, and it's going to, it's not ever going to be a straight line. But the death rate usually lags behind the infection rate. So if the infection rate keeps going down, for sure the death rate's going to go down. It's just going to be slower, or again, lag behind the infection rate. Because people who are already infected and who are maybe they've got infections that are going to be lethal haven't died yet. So it takes a while. It will take a few more days or a few more weeks. If you look at the death rates from age, look at us, all of us here who are over 45, you're at a much bigger risk than if you're under 45. And certainly if you're in your late 70s or over 85, you're at really high risk if you get this disease. And this is another reason why you want to get protected from the asymptomatic carriers. And of course, we can't tell who's asymptomatic. Well, it's impossible. Okay. So this really says what I just told you. What is unknown is if you're asymptomatic or you have low-level disease in younger populations, are you going to have long-term effects, especially to your lungs? There's something called lung consolidation where the cells in your lungs, after they've been infected, sometimes fuse to each other.
Hey, Rick,
And yes.
just want to remind you that it's 7:30.
Okay. Do I need to stop?
No, just, I don't know how much more do you have?
Just a few.
Okay.
Okay. Anyway, so long-term effects when you have lung consolidation, it makes your oxygenation less efficient. And if you have that in one little spot, it's not a big deal. But if you have it in many spots in your lungs, that can become an issue, and it will stay with you for your whole life. So what's next? Okay, vaccination will help decrease the infection rate, and it's going to decrease mortality. 3 new vaccines are coming online in the next few months. We should dramatically increase the rate of immunizations. They're going to continue, CDC and the drug manufacturers have to continue to study the longevity of the neutralizing antibodies following vaccinations, and also to look for side effects that are serious. Microbes mutate under environmental pressure, and environmental pressure is antibodies that can kill them. And so they're going to continue to mutate. And what I would guess is that there's a chance that we're going to end up having to have a vaccination every year or every 2 years. And it may not be. We may find that the vaccines that we have right now are working against all the variants, but I would guess that over time that's going to be unlikely. Should you take the vaccine? The bottom line from my perspective is yes, but it's important to remember, even the safest drugs, there's a small percentage of people who have serious side effects. When you decide to take a vaccine or any drug, you have to think about the risk benefit. So far, and this is short term, percentage of serious side effects is really low. And the only people who seem to have anaphylactic issues are people who traditionally have high levels of allergic reactions to a lot of things. We won't know about long-term side effects, if there are any, for years. The most typical side effect is fatigue and muscle soreness. And I think anybody's willing to say, okay, well, you're going to save my life, I can take a little muscle soreness. Maryland is terrible at getting the vaccine out, so I haven't had one yet, but if they ever get their act together, I'll get it as soon as it's available. Okay, there are myths about vaccines. I'm not going to go into all this because we're running low on time. There's an interesting article from Leanna Wen, who's from George Washington University, but she's also, you can see her on MSNBC or CNBC or CNN frequently. I don't remember which network. But the biggest myth is that the vaccine, because it's a genetic vaccine, is going to actually cause the virus to grow inside of you. That's not going to happen. And you don't have to worry about that. I don't think any of you are. Okay, the only other thing I will say here is that Regeneron, who makes a monoclonal antibody cocktail that reacts to the S protein, they have said yesterday, I think they came out with a press release that says if they give their monoclonal antibody cocktail to susceptible people ahead of time, that the rate of infection is very low. This makes pretty good sense in that if the virus level is low and the antibody level is high, you can attach the antibody to the virus, it gets cleared, and you're in great shape. When you get injected with a monoclonal antibody, it will usually stay in your circulation for 20 to 30 days. And so at a pretty high level. Once the virus, however, is already in you and replicating, you've got more viruses than you have antibody molecules. And so while it might, if you're already infected, it might make the disease less drastic, it's not going to stop it from progressing. And the help that you would get from that is that it will give your own immune system time to react. But there's not enough monoclonal antibody that Regeneron has produced to give to everybody. And even if you could, you would probably have to get 3 or 4 shots to make sure that you're covered while you're being exposed to asymptomatic people. Okay, that's it for me. I'm going to stop sharing and answer questions if I can.
Okay.
Yeah, thanks, Rick. This is Dan Rosignol. I have my camera turned off. A couple questions for you. One is what are your thoughts on vitamin D in people who are deficient versus people who have levels within normal limits? So, that study you specifically noted that those were people who were deficient in vitamin D and were supplemented compared to people who have normal levels. And this happened back in the days of sepsis, where they found that people who were corticosteroid deficient or unresponsive, they basically lacked a steroid response. When they were given steroids, sepsis cleared up almost as you watched it. But when they went and treated normal people with steroids, it had no effect.
Right.
So has there been an update on that? Because I take don't get me wrong, I take vitamin D every day because I live in the north and it's cold and I'm not outside. And even people who get out in the sun at our age don't make sufficient amounts of vitamin D.
Right. And of course, if you go online and look at, should I take more vitamin D? The first thing that they'll tell you is go outside. And that's the best way to generate vitamin D. There are, if you do a Google search, you'll find just tons of information about how vitamin D deficiency is not just an issue with COVID. It's an issue for a lot of things. And some of these are respiratory viruses or respiratory function. And so my thought is, after speaking to my doctor a couple of times, she said that increasing the dose of vitamin D when I was vitamin D deficient by giving me mega doses was not going to hurt me, but that was short term.
Right.
I do believe though that, and again, I'm not an MD, that taking at least the minimum daily requirement or somewhat a little bit more for me works. I don't know that it's protecting me from COVID, but I think it just makes me healthier.
And just to follow up on that, vitamin D is also implicated in treatment-resistant depression. And when you talk to doctors that treat treatment-resistant depression, one of the first things they do is test vitamin D levels. And the guy I talked to practices in Florida, and I said, is vitamin D deficiency simply a surrogate for people not getting outside and exercising? And we know exercise is good for depression. He said, I treat people in Florida where they're outside all the time. So at our age, the idea that just getting out in the sun is all you need may not be adequate. And so I'm an advocate of vitamin D supplements, and you can also readily test vitamin D levels when you go in for your next set of clinical labs. And it's something worth considering, and I'm glad you brought it up.
Yeah, and I will say that every time I have a blood test, when I go for my physical, they always include vitamin D as one of the tests. So,
Okay.
yeah.
Well,
Next
I can
question.
add on that, the NIH, I just put a paper in chat, which includes dosage recommendations, peer
Oh,
reviewed,
great.
that just came out. And I think also vitamin D helps with the calcium processing in bones, which, as everyone knows, is a dynamic process.
Right.
And Dana-Farber, where I've been going for what they've made into the little c, actually has me on vitamin D as one of the things.
Mm.
Doesn't mean it's necessarily good for you, but it just, people seem to feel it's, something you should do.
Right.
I'm
And
going
of
to try
course-
something different here.
Okay.
On a lot of people have actually written questions into the chat. I think it'd be nice
Yeah,
to answer those questions. Somebody asked, does prednisone inhibit the positive effects of the immunization of the Pfizer vaccine?
I do not know. By the way, I haven't looked at any of the chats, but that's a good question. Prednisone. I'm writing this down because I want to look it up. I don't know.
Yeah, I would guess that high dose prednisone, depending on the dose, is probably contraindicated, but I'm not an MD, but I'm an immunologist as well. And I know prednisone has pretty broad spectrum activity against immune reaction.
Right.
So
Yeah, it's used to shut down cytokine storms.
Yes, and it's shut down cytokine storms, but it also inhibits some of the cytokine reactions, as I recall. So
which are necessary for immune response.
right. And so one of the things is it needs to be balanced. Too much can be bad.
Okay, another question was, what do you think of a new study showing children spread it more easily?
I think that's probably accurate. Especially because it's harder to control kids, and if the study, which I haven't seen, probably says that they just have more virus to spread, that doesn't surprise me. And again, what happens though is what they might not have looked at is how long do asymptomatic children, how long are they able to spread the disease? Because maybe for the first week, they've got a lot of virus in their nose or their lungs, but a week or two later, their immune system has taken care of it. And I don't know. That'd be interesting to find. How are we still able to spread the virus after taking the vaccine? I see that one. Well, first of all, if you have the virus, or if you've had the vaccine and you get the virus in your nose, it's going to start to reproduce before the antibodies may have a chance to clear it, especially if you're early on from taking the vaccine. And so you can still spread it. That's probably the most likely scenario. And I know that they keep talking about, oh, you must continue to protect yourself even if you've had the vaccine. One of the reasons is that they're not sure, okay, the efficacy is supposed to be 95%. That means 5% of the people who get the vaccine might still come up with the disease. And maybe the efficacy is going to drop to 60% or 65 or 70%. So that would mean that you're still going to be exposed to people. There will still be people who have had the vaccine who can still spread it. Once everybody in the world has the vaccine, it's more likely that you're not going to have a problem with that, but you're still going to have people who can spread it. So.
I have a question for you, Rick. If you've taken the vaccine and it's been 3 weeks or 2 weeks and you haven't had your second shot, is there any protection?
Yes, there is some protection because your immune system is starting to build up. But the reason that they give a boost is because during that whole immune cycle where your immunity is being built up, you create what's called memory cells. And the second time you see the vaccine or a virus, let's say, but when you see the vaccine for the second time, your memory cells they jump on the vaccine very quickly and they expand very quickly. You have the B cells that turn into plasma cells that produce antibodies, and those B cell clones just grow at a tremendous rate after the second immunization. Now, I don't remember, some of the vaccines are 2 weeks, some of them are 3 weeks. Fauci said the other day that if you get delayed in getting your second shot, it's okay. I don't know how long you can wait for that second shot. Maybe 6 weeks, maybe 8 weeks. That has not been studied to my knowledge. It probably has been studied by somebody, but I just don't know. So if you're in a situation where you can have your second boost or your second injection on the time schedule that's recommended, I recommend that you do that.
Yeah,
So.
and knowing clinical studies, which are pretty carefully controlled, you tend to control it as much as possible. So I would have to say they simply do not know past the normal time window, which is probably, as you say, 2 or 3 weeks, plus or minus a week.
Right.
And to say that maybe it'll work 4 or 6 weeks out, 8, 10 weeks out, I find that very risky. It could be completely ineffective. As you know, in mice, you have a very good schedule and you follow it and it works. And when you start messing with it, things change and you don't know what you've got. So,
yeah,
those mice are there. They don't get delayed in their booster shots.
Right. Well, the other thing is mice are in a very controlled environment too.
Yeah.
Yes, I see a hand. I'm waving back.
Okay. My wife and I are rescheduled to get our shots tomorrow. And my question for you is, do you have equal confidence in all the vaccines that are currently available? And do you expect that these ones that become available later will be more effective?
I have equal confidence in the Moderna and the Pfizer vaccines. And what I will say on that is the recommendation is that if you get Moderna the first time, you should get Moderna the second time. I don't think they've studied getting Moderna, then followed by Pfizer, because those companies wouldn't have done that. In terms of the future vaccines, are they any better? I don't know. And the efficacy that the AstraZeneca vaccine showed was lower with their initial dose, but they had a set of patients and it was like 64% efficacy or effectiveness. But they had a set of patients who accidentally were given a lower dose, and the lower dose showed higher efficacy, which one of the things that normally happens in vaccine development is they'll titrate the dose, especially in phase 1 and phase 2, so they can limit phase 3 to 1 dose. But their phase 1 and phase 2 happened so quickly that they probably didn't get enough data before they went to phase 3. So the answer is, for AstraZeneca and for J&J, I don't know whether we can expect them to be better or worse. What we need to look at is the efficacy data that they present to the FDA. And again, being old-fashioned, I love the subunit vaccine that Novavax is creating, and liking adjuvants, I also like that. So, but again, if the state of Maryland calls me tomorrow and says, hey, we got Pfizer ready for your arm, I'm going. I'm not going to wait.
Okay, thank you.
Yeah.
And I'm thinking 95% is well above expectations, and to think that the Novavax would be better than that would be almost impossible to determine based on the sizes of the studies. If you look at the numbers, in order to get better than a 95% efficacy, you got to have many thousands of patients enrolled. And I don't know what the numbers would be that you would be able to see a differentiation between 95 and 97 or 98%. So to hit that 95% level is remarkable. And the Novavax is, and the Novavax and the AstraZeneca, the studies are about the same size. And unless a lot of the placebo subjects got exposed and got the disease, the numbers are going to be somewhere about the same in terms of granularity.
Right.
Okay, Rick, can you take a question from a youngster?
Sure.
Henry, ask your question.
Are the fever and cold viruses or diseases themselves, or are they just side effects from other viruses or diseases?
Are you saying when you take the vaccine and you get a fever, is that from the virus or is that from the vaccine? Is that the question you're asking?
No, I'm asking, is a fever or a cold a virus?
Yeah. Okay. Usually, almost all colds are caused by viruses, and the fever that you get sometimes with a virus, with flu or a cold, is caused by your immune system reacting to the virus.
Okay.
But is a cold or fever, or can a cold or a fever be a virus by itself? Can you is a cold or a fever a virus itself? Or is it
A cold is a virus, is caused by a virus, but okay. Now the fever itself is not a virus, it's a result of the virus.
okay?
Okay.
Good question.
I have one comment. My wife and I recently traveled to South America pre-COVID, and we received several MMR vaccines. And your comment that may have allowed us to have a little bit greater resistance to this disease was very encouraging. But my question is, if somebody had COVID, should they get vaccinated?
Yes. I believe, and you can check with the CDC, but I believe the recommendation is if you had COVID, that there's a certain time period you should wait until you no longer have it before you take the vaccine. And We can double check on that. But one of the reasons I believe that they've recommended that you still get the vaccine is because they don't know how long your natural immunity is really going to protect you. Just like they don't know how long the vaccine will protect you. And so.
By the way, I haven't had COVID. Just
Good.
to set the record.
Yeah.
That you know of. That you know of. You could have been
That I know of.
asymptomatic.
Yeah. I do plan, if I can get the blood samples, I do plan to do my own little study. And there's a company that actually sells blood samples to look to see if people who have had the MMR vaccine in the last year or 2 years, if serum from those individuals have antibodies that react with the S protein, because I have tons of S protein in my lab. And I'm at least 4 or 5 weeks away, and some big companies have probably already done this, but just for my own curiosity, I want to run these assays and just take a look and see what it says.
Are there titers available for people who got infected with COVID and had the MMR? Are the titers different in these subjects?
I haven't seen that. There's probably people, I'm sure that some of the companies that are working on this, or some of the researchers working on this, might have that data, but they may have even published it. I haven't seen it.
Because my question is the immune system, that immunologists will argue that you should get a vaccination every year anyway, just to keep your immune system revved up. Otherwise, it gets a little bit lazy in terms of the Th1 response. And some of the argument is for MMR that, you have a little bit of interferon gamma and your immune system's a little more revved up, and it's just more readily available to attack these things. So I think it'd be interesting, because what should happen is that the titers should not go as high in people who have had an MMR or had some sort of an immune priming reaction. And we know that if your interferon gamma levels are high, it's really hard to get co-infected with another virus. So
right, and what they did show on that one study is that you had lower level disease, or you were asymptomatic if your MMR titer, if your mumps titer was very high. And so your question is, does that correlate with your COVID titer? And that's a really good question. And so
we should talk some more about this, Rick. I also want to connect up with you, because I worked on a whole new set of different vaccine adjuvants. I developed a whole class of toll-like receptor 4 vaccine adjuvants that are outside the scope of this discussion, but
really,
yes. Talk to you about it. Yeah.
Send me an email. I'm sure it's on one of the things. I would love to talk to you about that. Somebody just posted a question on chat, and then I missed it. I think it was about the pneumonia vaccine.
It says, curious if pneumonia vaccine helps mitigate symptoms of COVID.
Don't know. Most of us, I would think, have had the Pneumovax vaccine, and but that would be an interesting question to ask, and to look at all these, especially with the mortality rates of older people. But that's something I hadn't thought about, so I'll see if I can look it up and see if there's anything online about it.
Well, it's very late back east, so I think this is awesome, Rick. As usual, you start out kind of like, what's going to happen, and it sort of stumbles around. And it's like a great singer, you get to a crescendo and you get smarter and smarter as you go. So really a great talk and very informative.
Thank you all, and anyone who wants, please. Oh, thank you. Anyone who would like, please send me questions. You have my email address. I don't often answer emails after 6 o'clock in the evening. I usually veg out in front of the television, but I'll answer them the next day or the two. So.
Question. question. He's been waiting a long time.
James?
Okay.
My 6-year-old, he has a question. He's been waiting a long time. Can he ask his question?
I'm 6 years old.
Wait, go ask the question, buddy.
But how many viruses are there?
Oh, how many viruses are there? Thousands, maybe hundreds of thousands. There are more than we can count. There's not a definitive answer for that. So, not all viruses make you very sick, though. So that's the good part.
Thank you.
Okay.
Okay,
I just wanted to-
thank you for your question, James. and
Thank
Henry.
you. Thank
Thank
you.
Great.
Very-
all.
very
Good night,
good.
everybody.
Bye.
Bye-bye.
Thanks a lot.
Thank you, Rick. Thank you.
Okay.
Thank you.
Thank you.
Thank you. Good talk.
Hey, Bruce.
Good night.